Good evening to all participants, PG students. So thank you so much, all participants. Once again, on behalf of RPG Life Sciences, I am Dr. Mangesh Bhalerao, Head of the Medical Affairs, officially invite all participants for the Nephrology Postgraduate Educational Program. And today we have with us Dr. Vinoi George sir to take us through the fifth session on the role of antiproliferative agents in renal transplant. So, without any delay, I would like to just go through the bit about the history, what happened last in the past. So, first session we had with Dr. Chaco Jacob sir, who spoke us on the kidney transplantations and its past, present, future. Then we had a second session on the management of long-term post-transplant complications by the Dr. Vishwanath Siddhini sir. Then on clinical transplant immunology, Dr. Shishirgan sir delivered a lecture on this. Fourth session was on the present and future of immunosuppression and drugs and the protocols. But today, for the fifth session, we are blessed to have Dr. Vinoi George sir. So thank you, sir. I officially welcome you for this session. The introduction in an introduction, sir, definitely, sir, doesn't need introduction as he is associated with the CMCH-Vellore Department of Nephrology, and he is working as a head of the department of the nephrology department. So thank you so much for joining us, sir. Over to you. You can share your PowerPoint presentation.
Thank you so much, Dr. Mangesh. Just want to take this opportunity to thank RPG Life Sciences and their team for giving me this opportunity to speak on the next few 45 minutes on the role of antiproliferative agents in renal transplantation. So I bring you greetings from Christian Medical College, Vellore and Hospital. This is our new campus, which we have moved in the month of October to Ranipet. And I would like to once again, thanks RPG Life Sciences for giving this opportunity. I have no disclaimers to disclose. And the aim of this presentation would be to highlight the current evidence of and possible practices of antiproliferative agents in clinical renal transplantation. Now, this presentation, I would give the review of literature of the role of the antiproliferative drugs. And this is in no way to denounce one over the other, but just to put everything into perspective when we do for the clinical practice. So this will be the brief outline and conclude with few words. So the modern immunosuppressive agents, when it came out of the antiproliferative, was azathioprine and mycophenolate. They were used in the combination of 2 or 3 agents of different classes, and they were brought in to prevent acute rejection and maintain graft function. Most frequently, it was combined with CNIs or steroids, along with the antiproliferative agents. And of lately, in the last few decades, the MP has largely replaced AZA as a first-line agent in primary immunosuppression because of a stronger immunosuppressive potency than azathioprine. So azathioprine per se, as an immunosuppressant, is an inhibitor of purine synthesis, affects DNA and the RNA synthesis. Its prodrug, the active agent, is 6-mercaptopurine that we all know, and it's definitely influenced by the enzyme that is which catabolizes that is the thiopurine methyltransferase, both of which are implicated in the toxicity of azathioprine, including with xanthine oxidase if either of the enzyme is inhibited. Azathioprine, as of now, the history it has been told it's like an old kid on the block, initially found by George Hitchings and Elion in 1957, and it was used as an immunosuppressant in the 1960s. It became as an experimental drug in heart and kidney transplant after Sir Roy Callan, the professor in Cambridge, introduced it. And when it comes to a brief note on the Indian history of azathioprine in India, in late 90s, this is the slide that I had got from my teacher, Dr. Chaco sir. The prices for azathioprine in Iran had significantly grown up by about 7 times, and based on a response from the transplant community, Mr. Subhash Pedrekar and Dr. Lal decided to indigenously produce them. And this led to the various trials for evaluation its efficacy, and CMC-Vellore was leading center, and it was successful and got published in 1991 in JAPI. Introducing the mycophenolate molecule, which became a new kid in the block in 1990s. It's a prodrug of the active agent of the mycophenolic acid. It reversibly inhibits the activity of the inosine monophosphate, which is predominantly located in the lymphocytes, which is the de novo pathway for the cell synthesis of the lymphocytes. So specifically blocking this, the lymphocytes, please note, they do not have a salvage pathway in which the inosine monophosphate can be synthesized from other purine analogs. Hence, the specific action on the lymphocytes made it a more potent immunosuppressant, which leads to the inhibition of T cell and B cell proliferation. Unlike the other cells, the eukaryotic cells like the skin, bone marrow, and the intestine, which also have the salvage pathway, the inhibitory properties specifically for the lymphocytes was a major advantage of mycophenolate, and that took over the azathioprine's role as a potent immunosuppressant. Now, when we look at both the drugs, the mycophenolate versus azathioprine, the early interest in mycophenolate when compared to azathioprine was bought in because of its specific mechanism of action, fewer drug interaction, and this was all with the hope to have a superiority over azathioprine, preventing acute rejections and prolonging graft and patient survival. Later, the interest became where people, the clinicians and the researchers were keen to know the longer outcomes of graft and patient survival and whether it was a cost-effective therapy. So the need for a comprehensive assessment of the comparative effects of the two drugs in renal transplantation started. So the journey began with the comparison of both the drugs, and I'm going to take you down the lane for the next of the 30 years of literature. There is enough evidence to use both in renal transplantation. The questions to answer is which is best or appropriate. Is both beneficial in the early and late transplant period when you look at the outcomes of early outcomes such as rejections and the late outcomes with regard to infections, malignancy, and finally patient and graft survival. And will all this translate to a personalized medicine of immunosuppression for an individual who comes in for transplant? So the profile of the antiproliferative drugs, the comparison of the data was actually, I started from 1990. This happened, remember, with different formulations of cyclosporin, tacrolimus, and the different induction agents. So initially in the early periods before 1980s, azathioprine was the sole drug. 13 years before it was introduced, before cyclosporin, it was the only drug along with steroids that were used in transplant. Then came the introduction of mycophenolate in 1990s. The tacrolimus came in between. Then you have the induction agents, which all came into picture between the period of 1960 to 1995. So this comparative data that y'all are going to be looking at is at different time points, different formulations of cyclosporin, different formulations of cyclosporin, and then tacrolimus, and the use of induction agents in between. So you need to look at this kind the comparative data with these few things in mind. So let me just take you down. So when it came to adult renal transplantation, as I said, it was the only drug that was before cyclosporin came into picture that was used in renal transplantation. Now I'm talking about the era from 1990 to 2005, when azathioprine and steroids were the only use. Rejection rates were high, toxicity and side effects were high. And then came MPA, which as a first-line agent to replace it. Acute rejection, and it came as a role in acute rejection and rescue treatment for, and the preliminary trials all showed that MPA could be used. This was later proved in 3 pivotal multicenter RCT trials, which were designed in 1990, in which mycophenolate and azathioprine was the comparative data of both the drugs along with cyclosporin and steroids were looked at. They definitely showed a reduction of acute rejection in adult diseased donor transplants. They designed similar to allow pooled efficacy dialysis. These 3 trials in 3 different continents were designed in such a way so that we could look at the data could be looked later on for pooled efficacy analysis. And I'll come to that shortly. So when you look at the timeline of the advance of use of mycophenolate renal transplant, if you look from the left to the right of the screen, the small pilot studies were started. The three large pivotal trials that came into picture led to the approval of FDA approval for the use of the drug. Now let us look at what were the three pivotal drugs, which largely replace azathioprine. The three pivotal drugs was done in US, the US RT mycophenolate study, the European mycophenolate cooperative study, and the tricontinental mycophenolate mofetil renal transplant study. These three studies were designed together. The inclusion and exclusion criteria were the same. And finally, for long term, they were looking at pooled efficacy analysis to see the outcomes of mycophenolate. Some points, the European and the tricontinental study used no induction, while the US study used rabbit ATG. The efficacy to reduce biopsy-proven acute rejections were analyzed in the first 6 months. Fixed dose of MMF of 2 grams, 3 grams, and azathioprine was about 100 to 150 milligrams per day. All the three trials looked at comparable among the groups. There were no significant difference in graft loss or death at 6 months post-transplant. The adverse events related to mycophenolate were predominantly GI, and they were dose-related. And the specific infection at that time point was high rates of CNP infection, which was seen with 3 grams of mycophenolate. Remember, at this time, there was no prophylaxis that was used for cytomegalovirus infection. So probably they attributed that to the high dose of mycophenolate. When it came to the efficacy in all the three pivotal trials at 6 months, it definitely showed it reduced rejection at 6 months. And at 1 year efficacy data, the prospective planned pooled analysis of combined data representing the patients provided a foundation for the disease donor transplant, saying the use of mycophenolate can prevent acute rejection. However, it did not firmly establish graft or patient survival benefits for mycophenolate when compared to azathioprine. So this inability of the individual trials to establish graft or patient survival at around 1 year was admitted and attributed by the authors to the low statistical power to detect the differences in events, because the events that were happening were very low. So it became important in transplantations. The long-term outcomes of these three pivotal trials. The first large trials were ever attempted. Second, they were prospective and randomized double-blinded trials. And third, the most unique was the approval of MMF was based on a surrogate marker for improved graft survival that was looking at acute rejection at 6 months. Now, why they looked at this pooled analysis of long-term data? Because the patients on the long-term follow-up dropped a lot. Some were lost on follow-up, and the events that were happening were low. And with these low number of patients, they noticed that there was significantly less graft failure with mycophenolate, significant reductions in the acute rejection group, and this established a long-term use of mycophenolate renal transplantation, leading to the replacement of azathioprine in the immunosuppressive picture. So once these three large pivotal trials were approved, quickly the clinicians and the researchers moved to try MMF and comparison of MMF and azathioprine in these three areas, looking at the safety and efficacy, establishment in pediatric patients, and efficacy in treatment of acute rejections. So when it came to pediatric renal transplant, during that period of 1990 to 2005, predominantly were observational non-randomized trials with or without induction, very small numbers. It just said that it had a tendency to reduce acute rejection. Hence, there was excellent graft survival. And especially in the ethnic race, the African American, there was a different reduction in the acute rejection. When it came and looked at the next point of using MP as a rescue treatment in refractive acute rejection renal transplant, 3 studies that predominantly observational and 2-phase trials, cohorts were studied in US and Canada, small numbers. The first part was those that were not responsive to anti-lymphocyte therapy were given high dose of IV steroids 5 days followed by taper, and another group, and that was maintained by 1.5 grams of mycophenolate administered for 6 months. What they noticed after 6 months following a rejection was there was a 45% reduction subsequently in the rejection that was treated with the MMF group. Whereas the other two studies were two-phase, which looked at rejection at 7 days and 6 months and compared IV steroids with MMF or AZA at rejection. And when followed up for 3 years, showed a 51% reduction in MMF group, but the overall graft survival and patient survival was similar. So moving from these three phases of saying that MMF was beneficial when to reduce rejection when compared to azathioprine, the early 2000s started looking on combination of MMF data, comparing data with other drugs, and also seeing whether they can be used with induction agents. And it's also try to see in high-risk group patients. Sorry. And because of its effective way of reducing rejection, thereby improving graft survival, I'm sorry, it was tried to see whether we can reduce the CNI toxicity by giving CNI-free regimes or steroid-free regimes to reduce the metabolic effects secondary to steroids. So looking at the combination of agents with other than cyclosporin, it was maintained as an adjuvant therapy or a maintenance immunosuppression with tacrolimus and cyclosporin. And when they used as TAC steroids or TAC mycophenolate and steroids or any other combinations, among the various groups, there was no significant difference in patient and graft survival, no significant reduction in rejection. And they said that MMF may provide a protection against the diabetogenic potential of TAC when compared to cyclosporin. This was the initial data that came in, and those are the references that were given below. When it was looked at sirolimus, it was said that there was a better renal function, that is pred, sirolimus, and mycophenolate. It showed a better renal function, a better cardiovascular risk profile, and a protocol biopsy at 2 years showed that 67% of them had normal biopsy, better graft function, and less inflammatory markers and fibrosis. So they concluded that combination therapy with tacrolimus and sirolimus may be superior, and also it can be superior to that of TAC and sirolimus. When it came and looking at the induction agents, again, this was the point in which the new induction agents were coming out. And initially, the polyclonal anti-lymphocyte agents were looked at. But because of the increased immunogenicity of the polyclonal anti-lymphocyte with the invent of monoclonal, the various monoclonal antibody induction agents were evaluated with the standard regimes that include CNI and also CNI avoidance protocols. Majority of these studies, remember, were non-randomized. They were prospective, often with historical control groups. The results were the same. There was similar patient and graft survival, no firm conclusions on steroid withdrawal or lowering cardiovascular risk profile in the presence of induction agents and using MMF. When it came to the use of high-risk patients, what they noticed that the immunological risk was not based on the immunological risk of disease donor transplant in the 4 trials. They looked at very specific populations when they looked at which were high risk for rejection, and they noticed that the African Americans, when compared to the Caucasians, had a lower risk for rejection. Now, the conclusion that they drew that low risk of rejection in those with MMF than AZA with induction, better graft function in those with pred and tacrolimus, pred and TAC and sirolimus, and similar graft and patient survival was seen at 1 to 3 years. There was no ethnic predisposition to subclinical rejection or CAN at 2 years, which is biopsy proven, whether the patients were maintained on steroids or withdrawn on steroids. So there was no ethnic influence in the outcomes that they studied. When they looked at the declining graft function, this was basically looked to reduce the CNI dose or whether CNI can be withdrawn with the addition of MMF, thereby reducing acute rejection, improving the graft function, and reducing the CNI nephrotoxicity. These results showed that treatment with the MMF had a beneficial impact on progressive renal function independent of a reduction in cyclosporin levels. But just with a word of caution, there was a significant physician selection bias in the cyclosporin withdrawal group. So that needs to be taken in consideration. The physicians were deciding on the withdrawal and the tapering dose of cyclosporin. And there was no control group to compare when the AZA was changed to mycophenolate. So in the first the 2 decades, by the conclusion, by the year around 2000, AZA had lost its charm and place in terms of primary immunosuppression. MMF became an adjuvant or a primary immunosuppression therapy in renal transplantation because it contributed to decreased rejection and improved graft survival. They also had a very brief mention of risk of cancer and lymphoma was low in the MMF group. The infections were dose dependent, especially CMV. And this concluded that MMF can be utilized in combination with all newer drugs, including maintenance and induction agents. When we look into the newer development of immunosuppressions, we need to understand that there has to be a balance between the immunosuppressive, the cumulative dose of the immunosuppression that we give. If it's inadequate, it can lead to rejection, which can also lead to allograft dysfunction, tubular interstitial nephritis, and fibrosis subsequently, whereas the excessive can predispose to infections like BKV and similarly cause an allograft dysfunction. Now, this prelude to the infections was already highlighted way back in 1990s in 2 prospective studies that were done with PRED and AZA, which actually laid the foundation for the understanding of one of the viruses, which was the polymoviruses. And this was a given warning that was given by Gardner et al., who said the detection of polymovirus infection is important as increased immunosuppression needs to be avoided to prevent possible complications. So this is way back in 1980, 2 small studies that gave us a warning of infections that can come in with the advent of newer immunosuppressions. And besides, in 1990, the diagnosis of BKV was delayed. It was misdiagnosed for acute rejection. There was a lack of knowledge, and there was unavailability of diagnostic tools. Some of our data from CMC-Vellore by our teacher way back in 1999 showed a timetable of renal transplant infections and noticed that those who had a significant infections, especially with cyclosporin, had a higher incidence of early tuberculosis, and late tuberculosis came in with those who were treated with PRED and AZA. But compared to the era of the cyclosporin use, there was significant occurrence of post-transplant TB with varying immunosuppressions. And it was noticed that those with PRED and AZA had a significant presence of late TB. Now, when this happened, the revisit of the use of MMF and AZA was taken. And the reason why this was relooked again from 2005 after 2015, there were certain doubts that were raised. Was MMF the only one that was making a difference? Or was it the CNI choice that was making a difference? As you would have seen in the previous slide, the older days or the older years, the original trial used for older formulation of cyclosporin whose pharmacokinetics were very variable, which probably gave the high risk of rejection, some of the researchers said. And after Way 90, with the new microemulsions of cyclosporin, they noticed, which had a very stable pharmacokinetics, there were reduction of rejections and improving of graft survival. So, relooking into the pivotal trials, one point that they found out, there was no further data that was coming out, and long-term outcomes were not available until 2012, when the Australian data from the ANS registry, in which the tricontinental study group patients were monitored and followed up in their ANS data registry, their data came out way after in 2012 with a 15-year follow-up. Now, these RCTs, the original trials lacked sufficient data to clearly determine the superiority of mycophenolate over AZA with regards to graft survival. And the authors did admit this was due to the limitation of lack of sufficient statistical power to detect the difference of graft loss and survival. Overall, as I said, the event rates were low, so this was not factored when the study was defined. And the second point, there was significant crossover in the treatment groups of people moving from AZA to MPA. Now, the statistical analysis that was used in these long-term outcomes were pooled analysis. Pooled analysis you use when you don't have enough statistical power, and especially when you're trying to do a long follow-up trial. So you pool all the data from the different centers. So you increase the power by pooling of the data in an effort to increase the sample size and the event frequency. Hence, you're trying to yield more reliable results. This cannot be an actual reflection for an individual patient, especially when you look at data from a pooled analysis of a group of patients. So let's look only on to those trials which revisited the role of mycophenolate and azathioprine in renal transplantation after the era of around 2005. Now, the first publication that came in was the MYSS and the MISS follow-up trials. That's a mycophenolate versus azathioprine for the prevention of chronic allograft dysfunction renal transplantation. A wonderful study, non-pharma supported, a purely academic study that was done. It had two parts. Looked at 336 renal transplant patients, divided into two groups of azathioprine mycophenolate along with PRED and the CNI. No induction was used. They looked at the rejection at 6 months. And the part two of the studies, they were followed up with those into two groups of those who had no more than 2 acute rejection episodes, no steroid rejections, and a serum creatinine which was less than 2 at 6 months. In these group of patients, the steroids were withdrawn. Now, the steroids were withdrawn to look if we could improve the graft function and also see the effect of MMF. After about 21 months and 60 months of follow-up, what they noticed was the cumulative incidence of acute rejection and graft and patient survival, the glomerular filtration decline. The new onset of clinical proteinuria taken as a marker of chronic allograft nephropathy, and the adverse events were all comparable between the two groups. There were no significant difference between the two. The other academic studies also substantiated this data, which came out in 2018 and 2015. There was no difference in the short-term or long-term outcomes between AZA and mycophenolate. When we look at the registry data, this is a study from the ANS data from Australia, where they looked at the patients who were enrolled in the tricontinental mycophenolate study group. These patients were in their ANS data registry, and they were able to follow up these patients because they used to get the constant data entered into the registry. These patients were followed up for 15 years, and they noticed there were no significant differences in the early and late outcomes. Though at 15 years, it was limited by small numbers, they found very little evidence for the superiority of MMF over AZA. The other registry data that came out from various countries also looked, and they said, look, there are comparable outcomes with graft and patient survival in the long-term follow-up, especially the one in Ojo et al., which came out in 2000 from the US registry. These were also done on specific populations or other clinical factors that could modify the impact of the immunosuppressive efficacy. Like, for example, looked at benefit of MMF in African Americans, different HLA matching categories, elderly patients with hepatitis C, diabetes mellitus, and the primary glomerular disease. All these done with specific populations could have an impact on the immunosuppressive efficacy. So the data from these registry data showed less rejections, but the overall graft and patient survival were almost comparable. So they conclude that it cannot generalize to larger kidney transplant population. And this was further corroborated in other organ transplant data, especially the heart. And the two systemic reviews, one of them was the Cochrane, in which they looked at about 6,000 kidney transplant recipients altogether, showed that no benefits of MMF or AZA was seen. And what was actually reported by most of the industry-sponsored studies were not confirmed in the subsequent academic studies. So by 2015, the conclusion that were drawn back was the feedback they got from the MYSS trial was half of the patient in the MYSS trial had at least one acute allograft rejection at over a 6-year follow-up. There was a 6.1% and 6.8% graft loss in the AZA group and the MMF group. In each of the treatment groups, 4% died with a functioning graft. In all these studies, antibody induction, steroid-free immunosuppression, and avoidance of calcineurin inhibitors would have played a role in improving these outcomes. and also in tapering and avoidance of steroids and CSA, which could have impacted the efficacy and the outcome of the studies. They also felt that the rabbit ATG was more effective, but also noted to have more adverse effects. They thought the IL-2 receptor blockers would be safer but less effective. With all this in place, they all noticed that there were the similar long-term graft and patient outcomes. And out of one of the most important point that came out from the MYSS trial was MMF was costlier than ASA. According to the paper, it was about 15 times costly. So they said that cost-effective and probably tailored to personalized immunosuppression could be used in a resource-limited settings. So whether MMF and ASA association in donation of brain death organs in disease transplantation going on in the background from 2006, they were recruiting patients, and they looked at how we could see whether MMF or ASA will improve the risk or the benefit profile of antibody treatment with an induction protocol based on a low dose ATG, which will probably prevent early acute rejection. And with the induction, they thought they could avoid steroids, use a lower dose of CSA so that they can reduce the CNI toxicity, which can subsequently reduce the chronic allograft nephropathy and the other metabolic effects due to CNIs. So this study was the Athena trial, looked at between 2007 to 2016. It was published in 2021 from 6 centers in Italy. And what did the researchers do and find? What they noticed, they looked at 233 recipients of a kidney transplant from a deceased donor who received dual induction and steroid-free maintenance immunosuppression with lower than standard dose of cyclosporin microemulsion. So the newer form of cyclosporin microemulsion was used. And at 4 years, they found out the cumulative incidence of biopsy-proven CAN, adverse events, rejections, patient survival, graft survival, delayed graft function, and the renal recovery was almost similar between the two groups. When at the same time with the everolimus coming into picture, there was enough studies going on to see whether conversion of a CNI to an mTOR-based regime along with the MMF, will it be beneficial? And always the question was which patients and when. Whether early conversion was better or late conversion better. These are the list of studies that concluded between 2011 and 2020. And at 1 year or 2 year analysis, what they noticed on substitution of a CNI with everolimus combined with MMF, the renal benefit was you get about an extra 8 to 10 ml of eGFR in the everolimus group. Rejections were similar. CMV and BK infections were less, and side effects were manageable. So the early conversion in the first 6 months in combination with MMF was suggested for those with low immunological risk after careful screening. And they noticed that those with good renal function, weak proteinuria, when I say it's less than 1 gram, but I would be a little skeptical to switch at this time point. Absence of previous acute rejections and appearance of donor-specific antibodies were some of the reasons in which they thought it would be useful. And graft biopsy was important before the switch. So when it came to all the data came in disease donor transplant, because that is what is the most common current practice in US, Europe, and in Australia. Very limited data was given in live related transplantation. And what I could definitely want to mention is about the Indian data, which came from Dr. Bansal from Delhi, from Gurgaon, where they looked at the live related donor transplants, and they found where they compared with azathioprine and mycophenolate with using IL-2 as an induction, and they found there was no significant difference in the subgroups with or without IL-2 blockers. Infections, death, and graft loss were similar, and definitely MMF was all the more expensive. What we learned in here in Vellore over the years of use of MMF Something that we realized what we have seen is we do a lot of therapeutic drug monitoring with mycophenolate because of the number of generics that are available in our country. And what we realized is as the duration, we maintain an AUC between 30 to 40. And what we realize immediately after transplant, because of the uremic milieu and the gut, the absorption of the drugs is very poor. And we tend to find very low levels. And as the duration of transplant increases, the green is showing more than 6 months, we noticed that the absorption of the drugs get better. And when you try to look at over a period of time, definitely the AUCs were much better after 6 months of trial. So what we learned was that different patients require, was given as not as a fixed dose, but as a milligram per kg. And what we learned was two things. Because of the AUC, we were able to adjust the dose of drugs. This reflected on the number of pills the patient had to take, and that reflected on the money they had to spend. Secondly, monitoring the mycophenolate levels, the risk of infections or the degree of infections, we were able to keep it at bay. Though we did have, but the therapeutic drug monitoring of the mycophenolate along with cyclosporin and tacrolimus was a much beneficial for us to reduce the infections in our cohort. So the evidence as of now, all studies, please remember, are done on donation after brain death organs. It cannot apply to live-related transplants. Based on the data, MMF can still be the first antiproliferative drug because it reduces early rejection. And the reduction of rejections, the induction agents, and the new formulation of cyclosporin and tacrolimus have played a role. MMF is costly and similar long-terms in graft patient survival. Can be a cheaper drug in a resource-limited settings, especially in a low immunological risk. MMF it can be done as a tailored therapy, looking into the patient's immune risk and reproductive status, adverse effect of the drug profile, risk of drug interactions, and the cost and the overall safety of each agent. One thing that most of the registry data said that all these clinical trial patients, if they are linked to a registry, they can be followed up in their own country from the registry data. So follow-up is very important. And something that we had learned was to understand the pharmacokinetics of mycophenolate and azathioprine, cyclosporin and tacrolimus, which was different for different patients. Hence, therapeutic drug monitoring has played a big role in our institute for the tailored immunosuppressions for different patients. So you all have the evidence, you all can be the judge. My opinion is for how to move forward would be a good prospective randomized control trial live-related transplants with a good follow-up for 5 to 10 years. Why I'm saying 5 to 10 years is to look into the good power for the study. They can be there so that there's no selection bias. We need to exclude the crossover patients, randomize them at the baseline itself, and use IL-2 induction, look into low immunological risk, monitor these drug AUCs, and look at the outcomes of infections and the graft survival, and along with the monitor of DSAs, in which you can all, based on the development of DSAs, you can look at the titration of the drugs. And obviously, if biopsy can be done with markers for fibrosis, that will be good. So till then, practice medicine wisely and honestly. Thank you.
Thank you so much, sir, for such an in-depth and covering all clinical aspects and finally giving your summarized opinion on what to do. And also you have given the pathway forward, what can be done. And thank you so much. I would like to ask participants, they can put up their questions in the chat box or Q&A box. Tomorrow, you would be getting the assessment link, those who have registered with us, along with the, once you give the assessment, you will be getting notes. After that, next week, you will be getting certificates of participation. You can download it on your link, which will be provided to you. So we can take questions, sir. We have a question like induction versus maintenance. What are the differences in immunosuppression? Suppression. So
Sorry,
this is
say that again. It broke up.
induction and the maintenance immunosuppression. What are the differences it carries in terms of immunosuppression?
So you have T cell depleting and non T cell depleting induction agents. As of now, we have IL-2 blockade, that is basiliximab, is what that we use, and that is, as I said, it is the data comparing both the induction agents shows no significant differences in the outcomes. Especially in the low risk group, we use the IL-2 inductions. The high risk group will be patients with, we use the T cell depleting induction, especially those who have de novo DSAs or a second transplant or a patient that is highly sensitized. That will be the induction agents. The maintenance immunosuppression, yes, we can start with pred, tac, and mycophenolate. You can start early days. We were using pred, tac, and AZA. Here in ours is predominantly a live related program, which forms about 70% about in our program, and 30% is the disease donor program. In the live related program, we do start at day -4 the immunosuppression, and we do move forward. But from the early 2000s, we have been using pred, tac, and mycophenolate. Patients who are not been able to afford or who have financial issues, we have used pred and tacrolimus. During the post-transplant period, when there are significant side effects of mycophenolate that do come in, which is predominantly the GI side effects, we first try to switch them to the sodium molecule because the sodium molecule has lesser side effects than the non-sodium. However, still, if the patient is not able to do, we switch them to azathioprine during the post-transplant period, and they do well.
Right. One question we have, should we do TPMT in all patients who are on azathioprine or before that?
We don't do it to decide on the patients on azathioprine. Now, the TMT levels are usually, they don't decide whether the patient can be started on azathioprine in early days. But however, especially if the levels are more than, I think it is more than 8 is a very high risk for an azathioprine induced side effects. But do these TMT levels reflect on the side effects? The data is still yet to come.
One question is there, can azathioprine be used during initiation of maintenance, or which are the patients to whom we can use it as an initiation?
So you can use them for initiation of maintenance immunosuppression. As I said, the low risk group. When I say the low risk group will be, patients, live related, same blood group with absence of DSAs, with a good matched kidney, at least a 50% HLA matched kidney, you can go ahead and do it. But please remember, about 25% of them, of the HLAs will not have a significant good matching as well. So you cannot just look at HLA, but definitely if it is a spousal trans, there'll be a less matching as well. But if the patients are not able to afford mycophenolate, azathioprine can be used in.
Right. But nowadays, if you see, the treatment cost is almost similar, or not that big difference is there. So the angle of cost effectiveness might not be. The another question is there, sir, how to deal with pancytopenia if it occurs with azathioprine?
So it all depends. If it is most of the azathioprine, we start at 1.5 milligrams to 2 milligram per kg. Doses of more than that is the higher incidence of leukopenia that you do see. How to deal with pancytopenia if it occurs with azathioprine? Well, what I would definitely do is I will definitely stop the drug, do a monitoring of all the total counts. And in that, remember, when cells drop, there are less tendency for them to reject. But so I will increase the dose of steroids and TAC, the CNIs a little more, till the the counts improve. Even if the lymphocytes or lymphopenia do not improve, then you have to look for CMV infections, very less likely to happen in the early transplant, unless and until we are thinking of primary CMV infection, that is, they had accrued even before transplant. That is one. But if lymphopenia along with anemia and thrombocytopenia, okay, go ahead. We should do a bone marrow. That is the first thing that we need to do, and see the reticulocyte count and see if there is a primary bone marrow failure. Most of these drugs are secondary to bone marrow. These issues are due to secondary bone marrow failure due to drugs. So how to deal with them? We stop the drug and try to manage with the pred and tacrolimus. And then once they are better, we still go with a low dose of TAC and try to maintain them with a low dose azathioprine and pred and tacrolimus.
Yeah, we have a question from MPH boardroom. So the students have gathered their answer. They are asking questions, sir, did diarrhea post transplant was higher with mycophenolate despite of keeping it in target range TDM?
So that's a good question. As I said, the initial absorption of the drugs are very poor in milligram. We give by milligram per kg. We don't use fixed dose. Initially, when patients come with us to diarrhea, the first thing we rule out is an infective causes. Most of the time, the infective causes for diarrhea come out, which can aggravate the side effects of mycophenolate. If the infective causes of diarrhea are ruled out, and if the TDM shows a very high level, we reduce the drug, and definitely the side effects do improve. The question whether the diarrhea post-transplant was higher with mycophenolate despite keeping it in, no, we didn't see much of difference. No, we didn't see much of difference. But the infective diarrheas were quite high when the immunosuppressions went in.
Right. There is a question we have received that, the diarrhea and the consequences, loss of weight, does it lead to the acute rejection rate in MMF? Has it some relationship with acute rejection? If we look at the colonic biopsies that have been looked at from MMF induced diarrhea, the reports definitely state about the cryptic atrophy, loss of villi, and cryptic pustules within the inflammatory gut. So there is a situation of chronic inflammation that goes on in the gut. This is very diagnostic of MMF-induced diarrhea when we looked at colonic biopsies. So chronic inflammation can lead to lack of absorption of, can cause a significant malnutrition and gut, which can lead to loss of weight as well. One differential diagnosis that we do keep in spite if there is no evidence of mycophenolate-induced diarrhea in the gut is the concern of a GI PTLD, post-transplant lymphoproliferative disease, loss of weight, diarrhea. That is something that we have to keep in the back of our mind when we're looking at chronic weight loss with diarrhea. Right.
Please remember, we have had also very resistant GRDSs that keeps on recurring. When patients come to us, we treat them, they better, and then they go back, and then they come back with. So it is a lot to do with the water source that they use as well. But the other differential chronic diarrhea with weight loss, GI PTLD.
Yeah. One more question: use of diltiazem for RNC absorption of immunosuppressant, does it affect? I think the question is, diltiazem affects the absorption of immunosuppressant.
Oh yes. So diltiazem is one of the drugs, especially that is being used to increase the level of tacrolimus and cyclosporin levels. So that can be used. It can be used as diltiazem. That can be used. There's no harm in using that. Yeah.
One question was there. I think you might have already covered the answer for it. That switchover protocol. What is your switchover protocol from MMF to azathioprine?
We don't, we just directly switch. For example, if someone with, we want to switch MMF because of MMF side effects, we stop MMF today, and the next day we start them on azathioprine. We don't have there's no tapering schedule that we do for mycophenolate. It's a direct switch that we do.
Right.
This is for a GI side effect for MMF.
Right.
The other question is of MMF-induced leukopenia. Most in nowadays, in the last 10 years of the use of PRED, TAC, mycophenolate, and the CMV prophylaxis that we use, valganciclovir, and along with Septran, you have a lot of leukopenic drugs that is there. The most common culprit is mycophenolate. We have never been able to, we can never prove it that mycophenolate is the leukopenia, but the tendency for most of the clinicians and most even among ourselves as well is that if we stop mycophenolate, will the kidney reject? Now, when you don't have much of cells, they're less likely for to reject. So what you can actually do is mycophenolate will be causing secondary bone marrow dysfunction and causing leukopenia. Reduce or half the dose of mycophenolate and then stop quickly and allow the infective prophylaxis to go on, because you grossly immunosuppressed your patients in the first 3 months. So that is what we do. But invariably, if the leukopenia is very bad, you'll have to stop the Septran, the valganciclovir, and wait for the bone marrow to recover.
Right. You have discussed much. You have also discussed many registry data and the outcomes. Do we have any effort where Indian registry or Indian databases can be analyzed, and we can try to resolve, or we can try to bring out more and more data on the azathioprine and mycophenolate mofetil? Would these retrospective trials help to understand it better especially in Indian population?
See, definitely it will help. The most important thing is you need to have registry data, especially from different cohorts from different parts of the country, in which you can look up. The most important is the follow-up of these patients. Now, without the follow-up of these patients, it's very difficult to analyze an outcome. So, yes, at least in the few of the centers of the 4 corners of our country, we can all get together. Definitely, we can definitely look at it.
Yes. So thank you so much for, sir, giving your valuable time. This is the 5th session of our postgraduate educational program. And we are really happy that you are there. Any concluding remarks for our the students who have joined us today?
No, thank you. I hope I was clear to them.
Yeah, one question is there, sir. Post DM fellowship at CMV-Vellore, is it there? One question the student has asked. If you can.
Post transplant DM fellowship, is that
post DM fellowship at CMC-Vellore?
We do have a post transplant fellowship program that happens after DM. Yes, if you're free to join, you're free to join. The exams are coming up in May, and most likely the interviews will be in between June and July. I think the forms will be should be coming out soon. So I can't see who has asked me, but please feel free to apply, and we'll be happy to meet you up.
Thank you. Very valid information for students, sir. Thank you so much once again for joining us. The edited video of this session will be available upon the approval of sir, and its link will be shared with you. You'll be getting notes. You have to also appear for assessment, and definitely the e-certificates can be downloaded, and post e-certificates you will be getting the hard copies of your certificates. So thank you so much for joining us today. Stay safe. Thank you.
Thank you.